Today we had a great session talking about a number of different trials. So you mentioned ASCENT-04. Triple-negative breast cancer has been the most difficult subset of breast cancer to treat in the metastatic setting. And in ASCENT-04, patients who had PD-L1 positive metastatic triple-negative disease without prior treatment were treated with Pembrolizumab and the antibody drug conjugate Sacituzumab Govitecan versus a KEYNOTE-355 type regimen with chemotherapy of choice, taxane or gem-carbo, with Pembrolizumab. And what the study showed was a marked improvement, statistically significant difference in progression-free survival. And I think the longest data we have to date about progression-free survival disease control in the first-line metastatic setting. I think some of the questions that have come up, I think first are the patient population, how does this apply to our clinic now? I think if we had that combination today, we would use the treatment. The second was, how are trials designed to equalize access that may also impact secondary endpoints. That trial allowed crossover to paid-for Sacituzumab Govitecan. Something that I feel really strongly about is important to equalize some of the tremendous inequities in access to drug worldwide. It's not as important in the US because people can get the drugs, but across the world, you have to pay out of pocket in many places. So I think if a patient puts the time and effort into being in a study and takes the risk of being randomized, that's an important outcome measure. A small number of patients crossed over and received the Sacituzumab Govitecan, probably because a lot of them could get it on their own, but also because patients have very aggressive disease. We don't know what other treatments they received. So it's going to be interesting to look at the longer-term data. Another question was, what happens to patients we see now? We give everybody who has at least stage 2 triple-negative disease Pembrolizumab and chemotherapy in the neoadjuvant setting, and we've seen very nice responses and outcome. We still see recurrence. So in the ASCENT-04 trial, you had to be at least 6 months out from your last treatment with curative intent, but very few people received a checkpoint inhibitor. So how will this work in patients who've gotten Pembro before and are 6 months out from their last treatment? Will it be an effective regimen in patients who we really struggle so much to treat, which are those people who are relapsing while they're on their adjuvant treatment? And we don't know the answer to that. I think we're going to need real-world data and maybe a focused study. So I think that's a big area too. We just don't know what prior Pembro does, although I believe that it probably will be still have efficacy in that setting. Those patients also have taxane-resistant disease, so it is helpful. Then the third question was toxicity. Toxicity was great. I mean, they had a low rate of discontinuations, saw the same grade 3 diarrhea rate of 10%, but overall, the toxicity of the key areas that we look at was less with Sacituzumab than with the treatment of physician choice. So I think it's very exciting data.